Health Canada recently granted a select few medical professionals and patients permission to use experimental drugs. Those drugs have actually been around, if illegal and taboo, for many years. So-called magic mushrooms and other psychedelics, it seems, could turn out to have some real clinical benefits. With us now to find out more, we welcome, in Port Townsend, Washington, Dr. Corinne DeBoer, Chief Medical Officer for the Multidisciplinary Association for Psychedelic Studies Public Benefit Corporation. In Marathon, Ontario, Dr. Ryan Patchett-Marble, Assistant Professor at the Northern Ontario School of Medicine and a clinical advisor for the advocacy group Therasol. And here in the Davenport area of Ontario's capital city, Rotem Petranker. He's a clinical psychology PhD student at York University and co-founder and director of the Psychedelic Science Research Program at the University of Toronto. And it's good to have you three with us here tonight on TVO. We are going to focus, I know there's lots of different psychedelics out there, but let's focus today on psilocybin, which I gather is better known as magic mushrooms, and MDMA, which is better known as ecstasy. Ryan, to you first. Health Canada recently approved some patients to use these drugs. What are the circumstances under which it's okay to use them?
Yeah, so in August of last year, Health Canada approved the first 4 patients to possess and consume psilocybin magic mushrooms. Those first 4 patients had terminal illnesses. And since then, there's been 1 patient that's been approved that has what you might call life-threatening cancer, as the studies call it, which means cancer in remission. But most of the people that have been approved by Health Canada have a terminal illness. So it's been approved to treat specifically psychological existential distress at the end of life.
Can you help us understand more about what that means? Psychological distress near the end of life includes what?
Sure. Yeah, so it includes things like anxiety, depression, and then this existential distress includes things like hopelessness, demoralization, fear of death, that kind of thing.
And how does it actually help under those circumstances?
Well, that's the million-dollar question, I guess. There's different theories. There's different ways of looking at it, too. One of the things that the 2 main studies commented on is that, very interestingly, the people that have benefit from it, which was a substantial number in the studies, they almost all describe some level of mystical component to the experience. And what I mean by that is these people have these experiences that feel like, they use words like, everything is one, sacred experiences, transcendence of time and space. They have this quality, what we call noetic quality, where this experience feels like it's more real than ordinary reality. So they have these really powerful experiences, often described in mystical terms. And for some reason, that seems to lead to immediate, substantial, and sustained improvement in psychological and existential distress.
I think we're all going to find out over the next 25 to 30 minutes how little I know about this topic, starting with the fact that I mispronounced psilocybin. Clearly, my youth was a little more G-rated than a lot of other people's was, because I just don't know a lot about this stuff. So, Corinne, I'm glad we've got you here to help us understand it better. MDMA, for example, how does that affect somebody's brain?
So thanks for the opportunity to speak here, Steve. So to explain a little bit why we're doing, what we're studying at MAPS is MDMA-assisted therapy for PTSD. To explain a little more and answer your question, I need to go a little bit into the biology of PTSD and how the effects of MDMA relate to that. So as we know, PTSD is a psychiatric disorder that may occur in people who experience an emotional trauma. One of the main focuses of PTSD and one of the main symptoms is hypervigilance, which means they're in a continuous increased state of alert. They're basically in the fight and flight mode, where a big rush of adrenaline is directed by the activity of the amygdala. And the amygdala are a part of the brain that are involved in emotional processing and also in memory. So what MDMA does, MDMA is a synthetic chemical. It has several effects on the body, and one of them is on the brain. And how it relates to PTSD, we know from neuroimaging studies that MDMA reduces the cerebral blood flow around the amygdala. And that results in increased mood and openness. And when the MDMA is provided with supportive therapy, as we do in our program with the therapists that are trained by our organization, the participant has the unique opportunity to go to the root cause of the trauma. And it has been effective. And I know we're going to talk more about the results as well.
We sure are. Rota, maybe you can come in at this point and talk about magic mushrooms and the impact they have on the brain.
Sure. So psilocybin, the so-called active ingredient in magic mushrooms, is very similar in structure to serotonin, which is a neurotransmitter that is, I think, really well known. We have SSRIs, selective serotonin reuptake inhibitors, that are currently our frontline antidepressants, and it appears that psilocybin interacts with the same system. We don't exactly understand how and where in the brain they work, and there's still a lot of research that needs to be done. But the way it appears now, at least from more, specific reports from individuals, from anecdotal evidence, is that actually psilocybin does the opposite of what people report from SSRIs. I think that a lot of people who take current antidepressants report that they become distant from the negative feelings that they experience, the depression, the anxiety, whereas people who use psilocybin often describe more feeling connected to these parts of them that they dislike and perhaps suffer from.
Are you prepared then to say at this point that they are more effective then than SSRIs are?
It is absolutely premature to say anything like that. They appear to be very promising, and in the limited scale studies that we have seen so far, the results are quite strong. But I think much more research is required before we can even accurately compare SSRIs and psilocybin.
Let me do one more with you, Rotem, and that is, I gather your specialty is microdosing. So explain that to us, if you would. How does that work?
Yeah, for sure. So microdosing is a practice of taking small subhallucinogenic doses of a psychedelic substance like LSD or psilocybin. And we actually don't know that it works yet. There is a real paucity of research on this subject, but it looks really promising because people are reporting that it's very, very useful for them in surveys that we've run. Thousands of people are saying that it helps with a variety of conditions, and it also helps their life just be better, feel better. It helps them flourish. It looks very, very promising, additionally, also because if it indeed works, when you take a very small dose of a psychedelic, it's supposed to not interfere with your daily life. So, for example, you could take a microdose and go on a TV interview, and that would not affect you at all.
Well, okay, I got to ask, did you just do that?
Oh, no, I didn't. But I'm just saying, it's one of the things.
You can't blame me for asking. You put it out there. Okay.
Absolutely.
Let me share this from the New York Times review from writer Michael Pollan's book. He's got a book out about psychedelics, and let's share this with our listeners and viewers right now. Many LSD or psilocybin trips, even good trips, begin with an ordeal that can feel scarily similar to dissolving or even dying. What appears to be happening in a neurological sense is that the part of the brain that governs the ego and most values coherence, the default mode network it's called, drops away. An older, more primitive part of the brain emerges, one that's analogous to a child's mind, in which feelings of individuality are fuzzier and a capacity for awe and wonder is stronger. Ryan, let me go to you on this, because you were approved by the Canadian government to use psilocybin yourself to develop therapy. Have I got that right? How accurate does that description sound to you?
That sounds very accurate. I think that it goes, as Rotem was saying, it goes against what we're used to, which is normally when people have depressed or anxious symptoms, we kind of try to suppress it or get rid of it. And what it's doing is allowing it to arise into this open space where it can be accepted and to some extent heal. So that's one part that I'm reminded of with the quote. And the other part is the default mode network and the ego. The way they found that out actually was they had people doing these MRIs for other reasons. And when they were waiting in the MRI machine before the actual, whatever the test was that day, they noticed a certain part of the brain lit up. And that was the default mode network. So that's the part of the brain that's there when you're ruminating. Like, oh, what am I going to do tomorrow? I said the wrong thing to that person. I really should do that next time. And so it's the part, perhaps, the neurological basis for self. And it seems to make sense that if that's true, that if you quiet that part of the brain, then maybe you feel more connected with others. And that connection can be really, really powerful.
Any concerns yourself personally about using it?
So yes, that's it's a really good question and a really big question. The studies that were done, and this is really, really important when you talk about this topic, they did a lot of things. So first of all, they screened people. They did 8 hours of preparation on average before the experience. They had trained therapists, and they did it in a conducive setting. So all of those things were done to obtain the results of the study that I mentioned earlier. And if you try to take shortcuts, it's unclear if you'll get the same results. I guess one example would be the polar opposite. You didn't screen someone, so you used somebody that had bipolar disorder or schizophrenia. You used untrained therapists in a non-conducive setting, like, say, a dark alleyway, with untrained therapists. You can imagine that's not going to go very well. And I think that that's really important to note, that the effect is not just from the drug and the dose, at least macrodosing, as I'm talking about, to contrast to what Rotem said. Those other things are critical. And I think I'm worried that as this moves forward, people might lose sight of that and forget all that other stuff that goes with it. It's not magic in itself, despite the name. It's not like, take this mushroom, don't worry about anything else, and you'll see the nature of the universe. It doesn't work that way. And I think that's really important to keep reminding people of.
Okay, one more for you. How do you plan to use your personal experiences to help patients in that regard?
So that's a really good question, too. So the short answer, I have my exemption. I haven't used it yet. It would be done in a setting with trained therapists and that kind of thing. The idea is that this is very different from other treatments that I give. It's not like prescribing antibiotics for a urinary tract infection or chemotherapy or something. The idea here is that my role as a therapist would be to help the person navigate through this terrain. And it's really unfamiliar terrain. The people that describe it, that go to these states of consciousness, they use words like ineffability. They say you can't really describe it with words. So me as a therapist, how am I supposed to read about this place that can't be described with words and then help my patient navigate through there? So the idea is, just like any other guide through terrain, that the people guiding have some experience with that terrain.
Okay, Corinne, I guess in the interest of treating all the guests equally, I probably need to ask you as well. Have you ever tried the stuff that we're talking about here tonight?
Well, thanks for asking, Steve. My personal experience is not important. What is important, though, is being able to share the results of our phase 2 clinical trials. So we recently published the long-term follow-up of our pooled phase 2 studies, which were 6 different studies of a total of 105 participants with PTSD, with an average duration of PTSD of over 200 months. And I'm happy to report that at the 12 months after the last dose, 67% of those participants did not qualify for a PTSD diagnosis anymore. And an extra 20% reported a reduction of their clinical symptoms. The other interesting part about that is that compared to the end of the study, 56% reported a loss of diagnosis. So even after the study is ended, more than 10 months later, participants continue to improve. And that is compared to 23% of placebo participants who did not qualify for a PTSD diagnosis at the end of the study.
Okay, 2 quick follow-ups with you, Corinne. Number 1, that was such an impressive, skillful dodging of the first part of my question. I'm actually going to let you get away with that because that was so good. And second of all, can we conclude, 2/3 reporting improvements, it sounds to my untrained ear like you would qualify that as a success. Would you qualify that as a success?
Absolutely. And I think it's also acknowledged by the health authorities because we have breakthrough therapy designation, which means the FDA provides support and will review our application in an expedited fashion. So in Health Canada, we just applied for a special access program in Health Canada as well. So they're very eager to look into that.
Okay, let's go over to Rotem now. What are you seeing in terms of findings so far and whether you're prepared to call what's happening a success?
Sure. So I think because my area of expertise is microdosing, and there's virtually no lab studies that have been published. There have been very few. I think it's really early to say whether or not microdosing even does anything. It's quite possible that the effects that people are experiencing from microdosing are just the placebo effect. That being said, I would like to tell you just briefly about the 3 main benefits and 3 main drawbacks that we've been hearing from people about. And so the first most commonly reported benefit that people are reporting from microdosing is improved mood. Almost 1/3 of our participants, and these are many thousands of participants, in different surveys have reported that their mood is better when they microdose. And then second is improved focus. So this is also very promising. People are able to focus on what they're doing more. And finally, improved creativity, which is not surprising because I think these substances have been known to assist with creativity for at least decades. In terms of the drawbacks, though, I think by far the most commonly reported drawback is that these substances are illegal. And I think that this also, it's funny, this when you asked Corinne if she's ever used these substances, it's funny that we feel comfortable talking about it on this forum, whereas if these were other substances that are also illegal, we would certainly not be willing to report our use of these substances on TV. So I think a lot of people who actually use these substances, a large barrier to their comfortable use is just the illegal status. So people are reporting that they have to deal with black market. They have to test their substances because they don't know what's in them. And they don't know how much to take because the supply is not consistent. So I think that this is more perhaps a failing of public policy than a property of the substance itself. Additionally, other very real drawbacks are physiological discomfort that people were reporting, kind of feeling hot and cold or gastrointestinal issues. And yeah, finally, just other calls for more research because they don't know if these substances interact with their existing medication. They don't know if there are health risks involved. So I would say that more often than not, people were just reporting that there's some physiological discomfort, but people are also reporting the same thing for just, off-the-shelf drugs that they can get.
Well, Ryan, that is one of the things I wanted to check out with you, in as much as if you can have permanent positive change as a result of the appropriate use of these drugs, can you have permanent negative change as well if you don't do it properly?
Yeah, that's also a good question. So I think yes, and that's why it's important we take into account that the research had those safety precautions, meaning, adequate screening, trained therapists, all that kind of thing, because people describe it being so powerful that it does come back later on. And that was one of the things that led to a lot of the fear about psychedelics was the idea of a bad trip. You'll have terrifying trips or flashbacks for the rest of your life. 8 doses of LSD and you're legally insane. These are the things that were being said. And if we look after how it's administered, so in the psychedelic literature, we talk about set and setting. So that's mindset, which is the preparation of the patient, expectations, the personality of the patient. Those things feed into the experience. And then the setting refers to the external stuff. So where is it being used? Who's around? That kind of thing. So it's really important we address those things to try to minimize the risk of having, terrifying flashbacks or something like that. I think it's really important to mention, though, too, that discomfort is not abnormal. And it's actually not something to look down upon because actually in the Johns Hopkins study, for example, which was the biggest one, it was 51 patients with life-threatening cancer. The odds of psychological discomfort or the percentage was around 1 in 3. And same with anxiety during the experience. And they don't view that as a bad thing. Again, it's the idea is that the discomfort is rising up that you've been suppressing into a place of acceptance. And that's actually part of the healing process, or at least that's one way of looking at it.
Corinne, I wonder if there are people for whom under no circumstances this ought to be considered as an option.
Well, we're working through the medical model at MAPS PBC, and the other part of our organization, MAPS, is working through harm reduction. We're talking about a different type of use, and rescheduling of the drug is actually very important because currently it's a Schedule 1. Basically, there's no approved use besides outside of clinical trials, and those are for drugs with a huge percentage of abuse potential. For this modality to become available, the DEA needs to deschedule the drug. And I think I want to also really stress the importance. This modality is not for everyone. And another important takeaway message for your viewers, MDMA will never be a take-home medication. It will always be the integrative model of MDMA-assisted therapy.
Rotem, let me follow up on this angle with you. And that is, I think this is an uncomfortable subject for a lot of people, in part because they have heard the stories about 50 and 60 years ago about how the CIA, sort of without people's consent, imposed the use of these drugs for testing purposes to see the reaction they would have. I think it was called the Montreal experiments because a lot of it happened up here. And And I wonder how much you think that affected people's views of the reputation that these drugs have.
Certainly, yeah, I think that's a fair question. And I think that, that it's likely that the misuse and the way the model of experimentation was back in the 50s and 60s had an impact on the way things are now. And yeah, the subsequent criminalization of these substances. And I think that it's important to remember that the setting is different now. These substances are currently being studied mostly by healthcare providers who are acutely aware of the current mental health crisis that the Western world is experiencing. And additionally, it's being bankrolled by corporations that see a lot of profit possible here. So I think currently it's being pushed very hard to show that these are the new mental health wonder drugs and that there's nothing to worry about at all. And for me, as someone who studies microdosing, this is particularly worrisome because I think in other models, you take a large dose of these substances, or maybe a few large doses, and that's probably it for life, maybe for now. But when people microdose, they do it once or twice a week for extended periods of time. And we don't know what the possible health outcomes of that behavior is. And I worry that in the current setting where a lot of people have a lot to gain, some of the less convenient results will be swept under the rug.
Well, let me follow up with Ryan on that. Are there ethical concerns that some patients nowadays may not be, intellectually capable of consenting in an informed way to the use of these drugs? What do you think?
I guess it depends on the indication you're looking at it for. I think it's important to know, I don't think this come up explicitly during this discussion, but in the 50s and 60s, there was like 1,000 clinical papers looking at 40,000 patients for a pile of indications. So this is not brand new. So it's not like everybody is a guinea pig. I think it's important that when we do start out with the clinical trials, we start out with people that are able to consent, where the benefit looks like it most outweighs the risks. And I think that's what we're seeing. And I think that it makes sense that the first major studies with classic psychedelics like psilocybin were looking at life-threatening cancer and the use in that population. I think they've been really favorable so far.
Okay, Kareem, we talked earlier about the standard antidepressant drug, they call it the SSRIs. And I know that a few decades ago, there was great hope that they would represent a huge breakthrough in the way that, for example, depression and anxiety were treated. And, in some cases, yes, and in many other cases, they've found to be no more effective than the average placebo, for example. I wonder whether you think we need to similarly temper our expectations for what these drugs can do in the same way that we've had to with SSRIs.
Well, I agree with you, Steve, and thanks for asking. So we carefully need to, even after approval, we need to carefully select the best patients for where this modality might work. There will be in our label some contraindications. For example, we know there are effects on the body of MDMA that causes an transient increase in blood pressure. So it's, from a medical perspective, not okay for everybody as well. And from a psychiatric perspective, people need to be carefully screened. And I also want to follow up. So what we're doing at MAPS is we're actually finishing off a lot of the good research that's been done in the 50s and 60s. We need to do a lot of training and advocacy work and explaining to patients what our modality can do and cannot do. The other really important distinction I want to make, Steve, with SSRIs are taking most of the time long term. And if patients taper them down, their symptoms are coming back. Our modality is intended to be used for a relatively short course of 3 months of 3 different sessions, potentially after approval, a little bit more or a little bit less for each individual patient. But as I shared with you with the long-term follow-up, even if the modality is not given, the participant is able to go through their trauma by the insight they've gained with the MDMA-assisted therapy session. So hopefully it's going to be long-term use, but we don't know. Long-term effects, we don't know how it's going to look extra long-term. So we're developing those studies as well. And I agree with you. It's not going to be for everybody. But we are very hopeful that at least it is another opportunity to treat PTSD that may be more effective in a field where basically nothing happened over the last 20 years.
Well, let me get Rotem on that. I know crystal ball gazing on this kind of thing is very difficult to do, but using your informed speculation on this subject, do you think that we are going to be hearing about and potentially using these drugs a lot more in the decade to come?
Certainly. I think that legalization for a lot of these substances is right around the corner, maybe a matter of a few years, especially for MDMA. Like I clearly know less than Corinne about this, but it is my impression that MDMA is currently making huge strides towards legalization, at least in the States. And I think that in Canada as well, I think that the health and health providers and the institution is very receptive, because truly the results are extremely promising, extremely encouraging, and there are some people that are doing incredible work. So I think it's really a matter of time before these substances are available for consumption. I don't know under which conditions, which is a huge question that is left unanswered.
Ryan, last 30 seconds to you on the same question. You think we're going to see more of this going forward?
Yeah, absolutely. I think that the term psychedelic renaissance is happening. I think that there's a paradigm shift happening in medicine, in our approach to mental health. And I think based on the studies, at least in my medical training, I was never taught about spiritual health. And what's being suggested with macrodosing, at least with these life-threatening cancer patients, is that a substance like psilocybin can lead to an experience which can lead to lasting change. And part of that experience is, it's hard to use the word other than spiritual. So that has a huge potential. And a big part of that is connection. And if you look at depression, anxiety, addiction, post-traumatic stress disorder, a lot of them have a huge underlying element of disconnection. And so feeling more connected in a lasting way is really powerful. And I'm excited to see where it goes.
Well, I don't know anything about magic mushrooms, but I do know about magical conversations, and that was one. So thank you all three for joining us tonight here on TVO. Corinne DeBoer from Port Townsend, Washington, Ryan Patchett-Marble in Northern Ontario and Marathon, and Rotem Petranker within spitting distance of this studio. Good to have you all on TVO tonight.
Thanks very much.
Thanks so much, Steve.
The Agenda with Steve Paikin is brought to you by the Chartered Professional Accountants of Ontario. CPA Ontario is a regulator, an educator, a thought leader, and an advocate. We protect the public. We advance our profession. We guide our CPAs. We are CPA Ontario. And by viewers like you. Thank you.